from Haifa, but it doesn't. It's a small it's a small can. Dobry den. I'm very happy and grateful to GE for inviting me to this symposium. I guess that the reason that I'm here is that for my 40 years of career in nuclear medicine, we have worked very close with what used to be LSINT and now GE. We went together from analog to digital cameras to CZT. And we in Haifa, and this is why it's important, Haifa, because it's very close to the factory, actually, of General Electric. We were always fortunate to be able to use the prototypes and to give the first feedback to the industry. So I was asked to speak about Spect CT, and when everybody is so interested in PET CT and in new PET tracers, the question is whether I'm Don Quixote fighting the windmills. And why is Spect CT so, by some of us, less admired? Because we were so busy and wanted to celebrate a new toy. And some thought that in nuclear medicine we worked for 40 years, so what else could be new? And it is definitely my opinion that PET is not enough, that we need some more. And I hope that by the end of the lecture you will agree with me. This was a paper that was published almost 10 years ago. I was part of a project that was sponsored by the International Atomic Energy Agency, and we looked at the first decade of Spect CT then. It is a paper that is read and cited every day a few times. And I think that by now we can say that up till 2 years ago, we already were speaking about classical clinical applications of Spect CT, both in oncology, in non-oncologic general nuclear medicine, as well as in cardiology. Now, we decided that it is about time that we revise what we knew. And we are this paper is going to be soon published in the European Journal of Nuclear Medicine. It was younger, most of the group was younger, some of us grew older, but we looked again at what has been published since 2007. We looked at more than 700 publications. We reviewed almost 500 that had larger enough numbers that we could draw some conclusions. And indeed, if we look now at what we know, there are, as you see in red, there are new agents that have been used with Spect CT. There are new indications that have been used with Spect CT, both in tumor imaging as well as in non-oncologic applications. And definitely much has changed also in cardiac imaging. Just to give you, at the beginning, a few examples of new or more expanded indications of Spect CT, we know that sentinel lymph node imaging started with breast and melanoma. Today, Spect CT is definitely used with much success in gynecological tumor imaging prior to surgery, as well as in the head and neck tumors. And these are just a few examples of the new images and the new types of display that can be obtained. This is another area where work has been done by a few centers, mainly in Germany. This is now that when SIRT is being used for treatment, the quantitation of lung shunting is very important, and apparently, as you can see here, there appears to be a difference between the quantitation using planar imaging and Spect studies, and this is something that really will need to be further considered. To summarize this part, we have introduced new clinical indications for Spect CT. We have started to produce peer-reviewed papers in larger number of papers, and we also have now a progress in technology that will change the focus towards even more interesting and appealing fields in our profession. So what is the main change in technology? This was a slide that I presented in the very early 2000, and I was talking there about the need for new technology, for new detector technology, and this is really what has happened. It has been also alluded by our chairlady, and we now have the CZT, the cadmium zinc tellurium detectors, which allow direct conversion. They operate in direct conversion. They produce images, or they allow us to have high sensitivity and better energy resolution. And for a physician like me, this is the best thing that I can show with an image, is that this entire part of the gantry or of the detector has been switched to a small 4 centimeter crystal. This is the first generation of the CZT imaging devices, and the first one that came to the market was the cardiac dedicated CZT Spect machine. We got it 12 years ago at Rambam. This is a phantom study where the time of acquisition was decreased by 75%, from 12 minutes to 3 minutes, with no change in image quality. And this was not only in phantom studies, but also in patients, as you can see in this case. Since then, a large number of studies have been published. They all show that that there is a statistically significant decrease in the number of suboptimal images, myocardial perfusion images. They also show that when you decrease significantly the injected dose and or the acquisition time, the image quality remains similar to what we used to see, and a very good correlation to the anatomic gold standard, which is coronary angiography. Furthermore, many studies have shown the prognostic value of CZT imaging using either full dose and rapid acquisition, or lower doses and a trade-off between the dose and acquisition changes. The next device that came to market was the molecular breast imaging, a planar device that uses, again, CZT detectors. I personally have no experience, but my colleague in Tel Aviv, Enat Even-Sapir, has worked with that, and she has many cases showing that sites of disease that were not known by mammography were seen on molecular breast imaging and changed the patient management. And from here, there was only a small step to providing us with the first general purpose CZT Spect CT, and this was installed in our institution almost 4 years ago. It was easy to install and easy to start to use, and this is just one example using on a planar scan, looking at the image quality for a renal study. The same good quality of images was obtained as well with Spect and Spect CT, and it is one machine that today, after it has been upgraded to the 3rd generation actually, is very much sought after by our technologists, and it is our patients are very happy with it because they lie below the camera, under the camera for much less time. So what has actually happened that after this 1st generation, we now have a new series of machines that provide us with novel options, both in the technological construction of the detectors, as well as some software options that lead to good operational efficiency. The patients are much more compliant, it is much more comfortable for them, and this, again, as I will show you, allows us to do some new clinical indications. One of the changes in software, or the novelties, are the swift scan, both on planar as well as on Spect. using that, we can improve our efficiency, our working efficiency. We can reduce either or both the injected dose and the acquisition time with no negative effect on image quality, and even improved image quality. This is a Spect study that was done with using the Swift scan, and this is a cardiac study that was done with reduced image acquisition time. Another improvement that is today available is the smart console, which gives us a smart way of communicating with our technologists, a good communication between physicians and technologists, real-time, and making real-time decisions on where and how to do a Spect CT study when needed. And this is something else that is available on most CT, standalone or part of Spect CT, and I think PET CT as well. And this is the way to reduce the radiation dose coming from the CT procedure. So where does it bring us now that we have this technological improvement? We can optimize patient protocols, we can improve patient well-being, we can reduce patient exposure, and at the end comes the real jewel in the crown, which is quantitation. So I hope that we have all read this editorial that appeared 10 years ago in the New England Journal of Medicine. If not, I think that it is very important for all of us who work with modalities that expose patients to radiation. What can we do now? As you can see, and as I have said, we can decrease the amount of radioactivity that is injected to the patient. We can see, and this has been proven in cardiology studies, that using the new technology, we can, first of all, decrease the time of acquisition or the injected dose, and we can provide stress-only cardiac studies in almost 40% of patients, reducing significantly the radiation exposure of our patients. And this is, if we needed some real proof, this is a study coming from the US where they show the decrease in radiation exposure to patients and to the personnel after the introduction of the CZT cameras. This is not really related to the radiation exposure, but it is one of our cases that we did, and that I'm always happy to show and maybe open some new indications for imaging in cardiology. Oops, sorry. This is a patient who had an inferior MI and PCI. He had a CT coronary angiography showing both showing lesions both in the left circumflex and in the area of the right coronary artery stent. This is his myocardial perfusion study showing an area of scar and ischemia in the inferolateral wall. But the interesting part was then when we put the two studies together, we could define that the culprit lesion was in the mid-circumflex, not in the area of the stent. And using our CZT cardiac Spect CT, this study was done in less than 9 minutes. There, as I have said, there is also the new technology in general nuclear medicine Spect also allows us to really reduce the amount of time that is being used for acquisition of whole body Spect studies. Whoop, that used to look otherwise on a different projector. But in any case, it's something that I truly believe in, and I'm using every opportunity to preach. I believe that in general nuclear medicine, it is time to let the horses go and move from planar imaging to tomographic imaging. And when you can do it in an acceptable amount of time, it is definitely something that we should do. And we should also be able to move from total body Spect to total body Spect CT in all cases where this is needed. The smart mark has been presented by the first speaker. I personally believe that it is mainly important in patients with infection, where, and especially in infection in areas close to metallic implants, as in this case that was provided by the Zurich Hospital in Switzerland. Another important option that we have today is being able to do simultaneous dual isotope imaging, and you can see that we can use it in various clinical settings. This is just one example coming from Lyon, where they did a dual isotope parathyroid adenoma imaging using technetium and iodine-123. Another important advancement is that due to the new design of the detectors, the brain reach, the quality of the brain studies can be much better, as in this case. And as you can see here, in a patient who had mild cognitive impairment, this new or the optimized image quality, as well as the quantitation, allowed us to make the diagnosis and to precisely demonstrate that there was a decrease in perfusion in the left temporoparietal region. And last, but definitely not least, very few words about the quantitation. Why quantitation? We think we have good eyes, but sometimes our eyes can cheat on us, and numbers can definitely help us. This is something that has taken off since we can do CZT, Spect CT for cardiac imaging. It used to be done only with Spect, and now Spect CT is doing it very well. This has been provided to me by my colleague, our cardiologist, who is finishing a 3-year fellowship in Canada at Ottawa Heart, and is working on that. But to the best of my understanding, that is some very important work being done here in Tomsk. Another area where I believe that there is importance for quantitation is in tailoring or in defining planning the treatment in patients with lung cancer who need to have surgery or radiation treatment, and you need to know what the healthy lung tissue reserve in these patients is. And since we think that we can really do better quantitation, not only in single lesions or single organs, but in multiple lesions throughout the body, this is definitely going to be very important in the diagnostic approach in patients with disseminated disease. And it's always amazing me how we can speak about different topics, but we come to the same main goals for us. We have looked at using quantitation for Lutetium-177 PSMA treatment. Yes, this is how you get what you see. This is how the images have changed. The upper row is the gallium PSMA. The bottom row is the lutetium PSMA with a therapeutic dose, the whole body Spect CT. But this was not enough for us. We saw it, and we saw it well with our CZT Spect CT cameras. We were really interested to see whether we are able to measure in vivo what is being, the true amount of radioactivity. So we did a study that measured using Q metrics the amount of radioactivity in the urinary bladder, and then asked the patient to void and measure the radioactivity in the well counter. And this is the correlation between the in vivo and in vitro measured lutetium radioactivity, and this is also going to be very soon published. So now we have solution to a lot of questions. We can inject lower doses, we can do faster Spect studies, and we get images which are with a much better quality. Now we have a problem. Now we have to really work hard to prove that this technology can have an impact. we have to work with our colleagues, the referral physicians, to improve the referral criteria and to expand them. We have to really provide large, if possible, multi-center and prospective study in order to standardize our scientific evaluation. And we have to demonstrate that Spect CT is of true benefit. Thank you very much. Спасибо за внимание.
Thank you very much. Спасибо за вашу презентацию. У кого в зале есть вопросы? Any questions from the audience? Да, позвольте, я спрошу. Сначала на русском языке. На самом деле проблема в том, что, или ситуация в том, что в России на самом деле сейчас только одна CCT-камера, и вот это, собственно, технология CCT, да, это очень действительно важно, и это революция своего рода, да, в спектре технологий, которая позволила действительно уменьшить время исследования или уменьшить активность вводимую. Но вопрос заключается в том, вот, собственно, эта технология, позволила ли она достоверно, статистически значимо увеличить чувствительность и специфичность выявления той или иной радиологической или онкологической патологии?
So, I want to make sure that I understood.
I can translate?
No. I just want, I was listening. Multitask is not my main quality. But you want to know how CZT cameras will change our practice in terms of sensitivity and specificity. Yes. Okay. So I think that for cardiac, they are already, looking at myocardial perfusion imaging, there are already studies that show the difference and show the improvement in the prognostic value. I think that for CRF measurements, right now, to the best of my understanding, I'm looking from the side. I'm not working on that, but I think that at this point, most studies have concentrated on evaluating or comparing it with the PET. And if indeed with CZT, cardiac SPECT studies, CRF studies can be done and can be done good, this will definitely have an important impact on a larger, much larger number of patients with coronary artery disease than have today access to PET, cardiac PET. Going to general nuclear medicine, my gut feeling is, and from our experience, yes, there is a difference. But, as I have said, we have to prove it. They are not enough because it's a technology that only comes from a single vendor and is available for 4 years, for 3 years actually. So now the studies have to start and come out to prove it. It's not enough. You don't have to believe me. We have to prove it with numbers.
Thank you very much.
Thank you.
Большое спасибо. Собственно говоря, если перевести вкратце, то суть заключается в том, что, конечно, касательно сердца, сама технология CCT, возможно, она не приводит к улучшению чувствительности, специфичности, но то, что мы можем оценивать микрокардиальный кровоток в коронарный резерв при помощи CCT-камеры кардиологической, вот именно этот момент, при накоплении, конечно, опыта, приведет к тому, что чувствительность, специфичность, практическая значимость этой технологии, она будет выше, чем просто синтезиация миокарда на обычной камере или на той же самой CCT-камере, только в аспекте того, что мы переходим на цифровизацию, на значение микрокардиального кровотока и резерва. Появились какие-то вопросы еще?
Very short question. How do you think the main potential of this technology is the improvement of existing nuclear medicine applications, or in the development of new tracers which can be more efficiently detected by CCT technique?
It is, it goes both ways. I think that as long as the technology has not improved for 60 years, people in the radiopharmacy industry and the researchers, the radiopharmacists, they were not really interested in providing new tracers. But it comes together now that there is a better technology. You can see, maybe you have heard there are already technetium-labeled PSMA agents. There are technetium-labeled glucose agents. There are technetium-labeled angiogenesis agents, which did not perform well in the research field as long as the technology was less good. So it really has to go in parallel. This is my personal belief. And we have to forget about planar imaging. Forget about it.
Действительно, поскольку АФЭК как технология была известна многие годы, уже более 60 лет мы ее применяем, и не ожидалось ничего нового, то те ученые, которые работают в области радиофармации, они не думали о том, что что-то изменится и потребуется нам новые трейсеры. И сейчас, когда действительно все это очень сильно изменилось, изменения коснутся, конечно, и радиохимии, потому что все эти процессы идут параллельно. И вы уже, конечно, слышали о том, что появляются новые препараты, допустим, ПСМА, меченый технецем, и препараты глюкозы, меченые технецем. И Ора очень верит в то, что действительно изменение технологий повлечет за собой то, что в радиохимии будут разрабатываться новые радиопрепараты. Ну и, конечно, она еще раз подчеркивает, что мы должны забыть о планарных исследованиях, что пришла эпоха аффект, и будущее именно за этим, а не за планарными исследованиями.
Спасибо большое. Появились еще вопросы в зале? Я хотел бы от себя добавить, да, что действительно это очень хорошо и здорово, да, что вот Spect технология догоняет ПЭТ в смысле цифровизации, в смысле того, что мы оцениваем не только по количественно визуально, да, что у нас появилась технология, количественной оценки данных Spect, и это приближает нас к ПЭТу и делает Spect и ПЭТ технологии более близкими.
Если вопросов нашим прекрасным докладчикам больше нет в зале, тогда позвольте подвести итог. Можно я расскажу по-английски, поскольку наши докладчики все-таки англоязычные.